Hello there. This is a dry eye talk, but at the same time not a dry eye talk. My lacrimal functional unit hurts is the title. I want to thank Dr. Michael Johnson. Originally this talk came from something that he did, and I helped present it in the Northeast because he couldn't get there. And then I did a talk for this in 2019 for the College of Optometrists. So I thought it might be a good idea to just sort of put it together for our website so that students and so on can have a look at it and ask questions. So first of all, I have no conflict of interest, but it is sort of about dry eye. And here's the statement. It says, the presentation discusses what to ask and what to do when examining patients who complain of ocular surface discomfort. A major focus of dry eye assessments is to identify and treat other conditions that may present similarly to or accompany dry eye. So that's the important point. And the other point I want to make is I ask people, please question things. You don't have to believe what I say. You don't have to accept what I say. I think it's really important you question everything and find your own truth. To plagiarize the Buddha. But I think it's important because people from above aren't always right, and you're perfectly capable of asking your own questions and coming up with your own decision. So this talk is as much about what dry eye is not. And I think as clinicians, this is really important. Now, I think most optometrists, if asked, would suggest that the Dews reports are pretty much the quintessential basis of our understanding and management of dry eye. And these were huge academic ventures, but I do stress the fact that they're academic. But in Dews 1 in 2007, they defined dry eye as a multifactorial disease of the tears and ocular surface, resulting in symptoms of discomfort, visual disturbance, and tear film instability with damage to the ocular surface. And it's accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. Now, for it to be considered a single disease, admittedly multifactorial, but they're calling it a single disease, they had to reintroduce a concept called the lacrimal functional unit, which is an idea, an integrated system of glands, ocular surface, lids, and sensory motor nerves. If you don't think of that as a single whole, then you haven't got a multifactorial, you haven't got a single disease. You might have a lid disease or whatever, but you can't have a single disease. Now, they changed, in 2017, they changed the definition, and this was done for a really good reason. It turned out that basically manufacturers were suggesting that you could have a global measurement for dry eye. If you simply tested osmolarity, and if it was above a certain limit, you could diagnose that as dry eye. Now, of course, osmolarity isn't a diagnosis of dry eye. It's a marker that something's wrong. But it was certainly being marketed as the single test required to assess for dry eye. So in 2017, they changed it and they downplayed the hyperosmolarity a little bit. They still maintain it's a multifactorial disease of the ocular surface, characterized by loss of homeostasis of the tear film and symptoms and so on. But hyperosmolarity and ocular surface inflammation play etiological roles. So that was a really important switch for them, I think. But what they still did was they still decided it was a disease. And they were the first people to do this. Prior to Dews, it was always considered a syndrome or a dysfunction, but they were the first people to actually introduce the idea of as a disease entity. Now, they openly admit there's lots of different definitions of what constitutes a disease, but they felt that there was enough there for them to be allowed to characterize it as a single disease. I have a few reasons why I don't believe this is the appropriate approach for clinicians anyway. And I have three reasons why I truly loathe the term dry eye at least. The first one is it does direct and constrain our thoughts. We become technicians, we measure things, and we decide that it's this, that, or the other, but we're following recipes. We're not clinicians. And that really annoys me. Dry eye becomes this default mode. Secondly, dry eye disease, if you want to call it a disease, is the only disease process that both disease entity and symptom, right? It's bizarre. Yes, I think you've got dry eye. Why do you think I've got dry eye? Well, because your eyes are dry. Oh, yeah, that makes sense. My eyes feel dry, so therefore I must have dry eye. But what if you said, well, actually, no, my eyes don't feel dry at all, actually. My eyes feel gritty. Does that mean you've got gritty eye disease? So it should never be a descriptor. I would never use dry eye I would try anyway, never to use dry eye as a descriptor with my patients. I would use the term gritty, irritable. I will try not to use dry eye because it gives in the patient's mind a concept that they've got a dry eye when actually they've got a gritty eye. And thirdly, dry eye is an outcome. It is not a disease. It is not a cause. If you've got blepharitis, you may get a dry eye. If you've got Sjogren's, you probably will get a dry eye. If you sit in front of a fan for 24 hours with your eyes wide open, not blinking, apart from being dumb as a bucket of mud, you will get a dry eye. So we're all perfectly capable of getting dry eye, but that doesn't mean we're all diseased. Now, if you accept that argument, where does it leave dry eye disease? If dry eye is an outcome, it cannot actually technically be a disease. So I'm afraid as a clinician, I don't accept dry eye as a disease at all. So in 2007, JUICE 1 came up with this nice flow diagram to help us all with dry eye at the top, and everything else flowed from that. Now, I always maintain that that's the wrong way around. It should be spun around the other way, upside down. And once you've filtered through all the other things, after you've filtered out everything else, you then may come up with dry eye at the very bottom. So, for instance, ocular surface disease, example, allergy. Now, if you diagnose a patient with allergy, you're not going to tell them they've got a dry eye, you're going to tell them that they've got allergy. Topical drug preservatives is another one. If you diagnose someone with that, you're talking about a toxicity reaction on the front of the eye. You're not really talking about dry eye at all. You're talking about toxins that are creating micro trauma onto the cornea. And also lid aperture disorders. Now, it's a very neat little diagram, but lid aperture disorders, that's three little words that mean a huge amount of clinical work before you decide that it's dry eye. So these flow diagrams are very nice looking, but they compartmentalize things down a little bit too simply. Now, since then, they have spun it around. JUICE 2, now suddenly dry eyes at the bottom, and you've got the presenting patient, and you filter through all these things. And certainly halfway down, you've got other ocular surface disease differential diagnosis. So again, a very neat looking little flow diagram. Well, it's not that neat actually, but it's neatish. But stuck in the middle there is that little red thing that means a lot of hard work, because that's what you've really got to find out. Your differential diagnosis is find out everything else that it isn't before it finally gets spat out at the bottom as dry eye disease. Now, what they have done, which I don't think any clinician really needed to be told this, but their great epiphany was to say that dry eye isn't just aqueous deficient and evaporative. There's no fine delineation between the two, but they can all morph into one thing. And we all know that as clinicians, you'll get patients back from hospital if they've got Sjogren's, and they're on absolutely everything. They're on a whole lot of stuff that's specifically Sjogren's, for Sjogren's, but they'll also be on blepharitis treatments and so on as well. And it's because basically they've got a tear film that's under a load of stress, and the ophthalmologists simply want to try to maximize everything. So they might do immunomodulators, they might do steroids, but then they're also going to tackle any meibomian gland dysfunction as well, so that what tears they have got will work as well as possible. So DEWS also gives us this very nice, or apparently very nice and very simple, it would appear, flow for your investigation of dry eye. It has a start, has a middle bit, and then it has the end. It has the outcome. Now, if you've got a dedicated dry eye clinic where the patient is simply paying you money to come in and have dry eye assessed, then this possibly might work. Although I feel it would fail, but it might work. So you have your questions, you know, do you have a dry mouth or swollen glands? And obviously that's targeting Sjogren's. Then it asks for risk factors, example, smoking, certain medications, and contact lens wear. Now they're only examples. I mean, there's hundreds of things that you probably need to investigate fully if you're going to understand the patient's presenting problems. Now, I'm going to suggest to you that that's nothing more than a case history, and we're all doing that every day, not just for dry eye patients, but for all of our patients. You're going to get to the bottom of it, and case histories, as you probably appreciate, don't stop after 5 minutes at the beginning. They continue throughout the test as new evidence comes to light. Then they give you what they're calling their diagnostic tests. So they've got their symptomatology, the dry eye questionnaire, and then their homeostatic markers. They prefer the non-invasive tear breakup time, osmolarity, and ocular surface staining. Now I'm going to suggest to you, in fact I feel I'm going to tell you, that these are not diagnostic tests. They are markers. That's all they are, they're markers. And I think the best analogy would be if you went to a doctor and they took bloods, and they said, you know, we've found some inflammatory mediators in your bloodstream. Now, what the doctor can tell you there is that somewhere in your body you've got inflammation, but that's all it tells you. It's just a marker. The doctor then has to use his or her clinical skill to find out what those markers represent in your body, and then they can treat that. So likewise, these are simply markers that something's wrong, but we have to use our clinical skill to figure out what it is. Then after all that work, which looks so simple, out the bottom gets spat. Basically, they come down to two things. You've got tear deficiency and you've got meibomian gland dysfunction. Basically, that's what it comes out as at the bottom. They also then love you to have your recipe of how to do it from a non-invasive technique first through to more invasive, which is obviously logical. But I'm going to suggest to you later that we do this all the time anyway. You don't have to think about it specifically the way they do. And then after that, they then give us very kindly their step-by-step algorithm for how we, as let's call ourselves clinicians rather than technicians, would treat dry eye. Now it's pretty much the same as the one in 2007. They've got a couple of extras in. They, for instance, now talk about tea tree oil treatment for Demodex, which wasn't in the original. And what you've got to appreciate, this is basically a meta-analysis, right? Demodex wasn't mentioned in 2007 because it really wasn't apparent in the literature. People weren't talking about it. But since then, it's become a pretty popular topic. And therefore, there's a lot of literature about it. Therefore, it turns up in 2017. Now, I don't know if you understand this or even believe this, but believe it or not, Demodex did exist 10 years ago. It just wasn't really written about in the literature. Now, other things they mention, they talk about ocular lubricants in step 1, ocular lubricants of various types. But then in brackets, if MGD is present, then consider lipid-containing supplements. So basically what they're saying there is, if you've diagnosed something else, you've specifically diagnosed meibomian gland dysfunction, then treat meibomian gland dysfunction. And they also talk about preservatives and when you should be thinking about non-preserved drops and so on. Now, you know, if you want to be a recipe follower, I guess this all works. But I consider the thought is that if you diagnose someone with Demodex, you're not going to say, well, I'm going to go through step 1 first, because that's what the algorithm says. you're going to treat Demodex, aren't you? And I do also think, incidentally, on Demodex, you don't have to go plucking little blighters out. If you've got greasy lids, you've got Demodex, you know. And if you're over 60 and you've got greasy lids, you've got Demodex. Now here's one that I rather like. This is by a guy called Vitali, and classification criteria are not necessarily appropriate for use in diagnosis and may lead to misclassification of a disease. In an individual patient, a classification scheme can provide a guide, but an expert clinician applying appropriate diagnostic criteria is needed to establish a diagnosis. That was about Sjogren's, and I think you might notice that the journal is Annals of the Rheumatic Diseases. But this is what we need to be. We are clinicians. We are not recipe followers, and we need to have structure to how we're going to investigate this very, very complicated set of things. Because we measure things. Optometrists are renowned for measuring things. We measure all sorts of things. And as I say at the top there, technicians measure things. Clinicians do what's important. But we love it, don't we? Every now and then they come up with a new thing. Several years ago they came up with lid wiper epithelium. Everyone went mad about lid wiper epitheliopathy. And when you think of it, did it actually change what you do with the patient? No, it just gave you another thing to measure. Clinicians have to think more specifically than that. Now here are some modified definitions created by clinicians, not academics. There's one in particular there that I think is very, very important. Now, Michael Johnson says, as a clinician, my focus is not on giving names, but rather on treating problems. So he says, symptoms consistent with dryness that bother the patient enough for them to want treatment, that's important. The patient has to want to do something. And then other causes are excluded again, then he'll treat. If there are signs of dry and the patient isn't bothered, and as long as the cornea is not anaesthetic, then, as he puts it, I don't care either. And that's a remarkably pragmatic view to take. This guy's dealing with these patients in a hospital setting all the time, and he's not going to muck around with stuff. And I think that makes perfect sense, and it's a good pragmatic approach to a very chronic common problem. Friedlander from 1992 says, and again, he's talking about rheumatic diseases, so he really brings it down. He just thinks there's only two sources. There's a modest decrease in tear production associated with age or medications, and those with severe dry eye, especially middle-aged women. Now, the bottom one, though, this is mine, and this is very much a reactionary definition. I'm reacting to the Jews one. So in my opinion, dry eye is, in brackets, not a multifactorial disease, but rather a multitude of interrelated but distinct morbidities, disrupting tear dynamics and subjectively resulting in irritable, uncomfortable eyes. And if unmanaged, these distinct morbidities will result in loss of ocular surface homeostasis, increased tear osmolarity, and ongoing ocular trauma and inflammation. So if you look at that multitude of interrelated but distinct morbidities, you're basically talking about that is dysfunction of the lacrimal functional unit. So something's gone wrong with whether it's the lids, the glands, whatever it might be, that's what's happening to the lacrimal functional, and that results in this dry eye. So thinking now as clinicians rather than recipe followers, if we go back to the original 2007 Dew's flow diagram of dry eye, the upside down one, it's neatly written and everything, it looks nice, but what it's really representing is really huge. For instance, lid aperture disorders. What does that actually mean? What are we having to wade through to figure out that it's a lid aperture disorder? Even meibomian oil deficiency, what does that actually mean? So for students, to try to get them to understand how potentially complicated this could be as a clinician, I sort of expanded the whole thing. So under lid disorders, for instance, I've got blinking disorders, lagophthalmos, Bell's palsy, incomplete blinking, reduced blink rates, lid disorders, trichiasis, entropion, ectropion, tylosis, all of those things And under blepharitis, in fact, meibomian gland dysfunction, lid disorders, I just say, well, we've got to go then to a whole new section purely dealing with blepharitis. I've got a whole fact sheet just on blepharitis because that's a complicated subset in itself. It's not just blepharitis, it's what sort of blepharitis are we dealing with. And as clinicians, we have to wade through all of that before we can ever start considering how we're going to manage the patient. So how do we do it then? This is the real point. We have to have a structure and logic, and we use this term sieving. It's a thought process in medicine. It is a structured examination when challenged with a question. Right? You don't just dive in there and say it's dry. You say, I'm going to find out what's actually wrong. And there's different sorts of sieves. I'm going to go through a couple. There's a patient sieve, which is fundamentally case history and observation, anatomical sieve and a medical sieve. And it's just logical. And if you stick to this, it helps a lot. So by sieving, you hopefully can really get to the hub of the problem fairly promptly without, in a recipe fashion, just going through every possibility there is. So, I mean, as the patient walks in the door, you just watch them. How do they walk? Do their joints look okay? How's their breathing? Is their skin okay? Have they got acne rosacea or dermatitis? And obviously, if you see that there is yes, or how do the lids look? Have they got blepharitis? In this case, ectropion. And obviously, that prompts questions fairly quickly as to where you might be heading. Or indeed if the patient even has problems. Now, of course, once they're actually in the chair, you need to really nail it down a little bit more specifically about the general health. And I personally feel the best way to do this is simply to really get out of them all of their medications and their general health. Now, we're all taught to do this. We're all told to do it. We need to take a drug litany. But I'm not sure that optometrists necessarily do it terribly well. We certainly list drugs, we ask them things, we note it all down, we maybe don't spell them correctly, we're not really sure what they're all for anyway, and then we move on. Well, the thing is, if you're going to do it at all, you might as well do it properly. And here's an example from a case record of mine, or from my practice some time ago. And at the top you have a list of problems, and then underneath a list of drugs, not in any particular order. There's no real link between any of them. And I would ask, and this is how many optometrists write things down, and you say, well, is that any use? Is it very helpful? Unless you know your drugs profoundly well, I'm not sure that there's a direct link. So it's not easy to make a prompt assessment of that patient based on that pile. It's much better to do this. You learn a lot more doing it, and then it makes sense. So this is the same list of drugs, but now we've put it in order, and we know that gentleman's got emphysema, COPD, and they're on several inhalers. The prednisolone is for the COPD, nothing else, and they're also on carbocysteine, which is a mucolytic for breaking up mucus on the lungs. They've got osteoporosis, got back pain. For blood pressure, they're on enalapril and they're on aspirin. And suddenly it all makes a bit more sense. And you know, for instance, maybe that patient's been on those drugs for some time, but suddenly they come in and they say, oh, about 6 months ago, I went on a new drug. It's called detrusitol. And in the case history, you find out that they're also getting symptoms of ocular irritation. So that becomes a red flag. You think, right, that's possibly a coincidence, but we don't know. The irritation started about the same time and they've gone on to detrusitol. What is detrusitol? How do we find out? Well, there's a website called Electronic Medicine's Compendium, and you just type the drug in and find out, and you can do it in front of the patient. And you look for what we call Summary of Product Characteristics, SMPC. And in that, it tells us that detrusitol is a drug used for urge incontinence. So patently, it dehydrates you. Now, since it's designed to dehydrate you, it dehydrates you everywhere. And as you look through the summary product characteristics, you find out that one of the adverse drug reactions of detrusitol is to give you a dry eye. And that makes perfect sense because that's its mode of action. Now, incidentally, if you did, what you'd also expect would be this would be a tear deficient dry eye. So again, as a logical clinician, if you're then assessing the tears and you think, well, there's a huge tear meniscus and there's patently loads and loads of tears, then actually you can't really blame the detrusitol. It may be just a coincidence, because this sort of drug would have to cause a tear deficient dry eye as opposed to anything else. And at least if you know that and it all works out, you can say, well, I think this is why. Now, patently, you're not going to take them off the detrusitol. You'll say to them, well, it's inappropriate to remove this drug. You need it. It's an essential drug for you. But at least it explains your symptoms and the signs that I'm seeing on the front of your eye with poor tear volume. And we need to keep you on it, but at least we can manage the problems. And the patient then understands it. So that's always important. Patient understanding of the problem is really critically important. So the trouble with doing this is it's time. And if you get practice at this, it does become quite easy, but initially it can be difficult. And especially if you're doing a 20-minute sight test, say, I can appreciate that's hard. But if you're going to do this and if you're going to investigate this, this is actually a really critical point. You need to know the patient and you need to know their drugs. And, since we have limited time, it is important to try to only ask important questions. Don't ask a question or measure something that won't influence your decisions. Now, of course, that's easier said than done, because you don't know if it's not important until you ask it and find out that it's not. I mean, we're not going to ask generally, do you ever have a dry mouth? Now, that's not a question that springs out of a normal case history. Okay, again, if the patient was in for a clinical dry eye assessment, then it would come out, but not a general patient coming in when you're just investigating them generally. And it would come maybe later. And as we all know, case histories do continue throughout the exam as new evidence comes forward. So, for instance, this patient here, or this eye attached to a patient, the patient did not report a problem. Now you'd think, oh my goodness, they should have. But this patient did say they had a dry eye when they came in, but they didn't report that. That was a question later. They were only coming in because they felt their vision was a bit blurry. And it was only until we put the slit lamp around that we thought, oh my goodness, what's going on here? And that prompted further questions. We found out that we already knew they were on viscotears, and I actually asked the question, how often are you putting the viscotears in? And they said, well, actually my eyes felt so dry, again, bad term, my eyes felt so dry, I've been putting the viscotears in 14, 15 times a day. Now, viscotears has cetrimide in, which is a cationic detergent preservative, and it's toxic. So this patient actually didn't have a dry eye, they had a toxicity problem. But all this evidence comes forward as you're examining the patient, as you're sieving. Now, considering the lady in the previous slide, imagine she wasn't on viscotears 14, 15 times a day, and you saw the signs you saw, and perhaps the tear prism was very, very low, and from your case history you already know she had perhaps rheumatoid arthritis. That most certainly starts prompting really valid questions about dry mouth. And this, I want to introduce you to the revised international classification criteria for Sjogren syndrome. This was written in 2002, but it is still valid. And it has 3 very simple ocular questions, 3 not always so simple oral questions, and 2 ocular signs. In the oral questions, the one, do you frequently drink liquids to aid in swallowing dry food, is spectacular. That's a really good one to have. It's not just does your mouth feel dry? That one is really far more specific. The one about recurrently or persistently swollen salivary glands is a bit dodgy. I don't feel patients necessarily know how to answer that. But then the 2 ocular signs are the Schirmer test, or in my case, the phenol red thread, and the Rose Bengal score. But again, in my case, I use lissamine green. And if they come out as positive in these, there's a very high likelihood that they've got Sjogren's. Now, the Van Bie scoring system, this was a Dutch ophthalmologist who came up with this in 1969, so it's quite old. It's very, very straightforward, and the point is it's really, really quick. You can do this really quickly. There's no mucking around. You put in your rose Bengal, or in my case, lissamine green. You divide the ocular zones up into 3, cornea, temporal, and nasal conjunctiva. And you simply see how it stains. Now, if it doesn't stain at all, if each zone doesn't stain at all, that's 0. If it's confluent staining, it's 3. And you very subjectively just divide it up and give it a score out of each one out of 3, 1, 2, or 3. And if the score is 4 or greater, then that's a positive sign that this patient has a tear deficient dry eye. And of course, then you also do your phenol red thread to see if the volume's there, and if the volume's low, then the chances of this being a true tear deficient dry eye is very, very high. Now, academics, optometry academics, will hate this. Sensitivity is fairly poor, specificity is fairly poor. It's not one of those beautifully quantifiable things. That's not the point. This is really quick, and it dovetails in with what you've already done. The questions, a good case history, does the patient fall into the demographics that you would expect? And this makes this a very, very quick and simple test to do. And that's how a clinician works. Are truly ophthalmology-based ones, or and histopathology, salivary gland biopsies, and so on. These are the gold standards. But the point is that those first 3 we can do very, very readily. And to my experience, anyone that passes all that, or fails, if you will, those other sections, I've never referred someone that hasn't turned out to have Sjogren's. Now, the pattern sieve, continuing with the case history, is it the primary presenting complaint? That's really critically important. If it comes off as something later, well, that patient before, that was serious. But if it's the thing they sit down and say, actually, I'm here because my eyes feel really gritty, then yeah, you've got to investigate something. So it directs your attention towards that area. Again, as we said, technicians measure things, clinicians do what's important. Is it laterality is important? Is it monocular or binocular? Duration, months, days, hours. Is it gritty, achy, stabbing, itchy? And does it ebb and flow? Is it constant? Does it evolve over a day? Is it non-waking? All these things are important to ask when you know it, when it's come up. So you start digging deeper based on the initial questions or answers that you're getting. Laterality again. If you've got a unilateral tear deficient dry eye, you've got something bad, right? If it's drug induced, it's going to be bilateral. But if you're truly not producing enough tears, you either have to have a lacrimal duct scarring or a lacrimal gland carcinoma. If it's bilateral, it could be hormonal, reduced corneal sensitivity, and medications again. So again, all these things here could fall within your differential diagnosis when someone turns up with an irritable eye, that you're trying to diagnose something that's not dry eye. All of those things, and some of them would be unilateral, dacryocystitis, microbial keratitis, all those things, and bilateral evaporative dry eye would be bilateral blef, Demodex, and so on. But I'm going to stick to dacryocystitis for a moment, because I've got a patient that had me quite confused for over 12 months to explain the confusion and how, as a clinician, you can get muddled up. And in hindsight, I shouldn't have done, for a very obvious reason, but I'll show you. This patient here, pretty much all of 2018, this patient had low-grade chronic oscillating symptoms of ocular irritation in the right eye only. She was a contact lens wearer, still is a contact lens wearer, and one thinks, is contact lens a red herring or a red flag? Could be anything. But honestly, it went on. We just couldn't get to the bottom of it. It was low grade. There was nothing very much to see anytime she was in. It was just uncomfortable and irritable. We tried various lubricants. We tried topical steroids. We tried at different episodes. She had her Lacrimal syringe at the hospital because she also worked in the hospital, so she used to pop in there. And between the hospital and us, we basically got nothing right for about 12 months. Until finally it became acute, and that's when we realised that what she actually had was dacryocystitis. But when it was chronic, it was low grade, there was nothing much to see. All we knew were the symptoms that was irritating. Now the clue was in the fact it was unilateral. You know, a dry eye really technically isn't, but dacryocystitis certainly is, but there was nothing to see. And as I said, it wasn't until it became acute that the penny dropped and we were able to do it. Now since then she's had a DCR and she's much more comfortable now and we're all happy. But you know, 12 months it had us confused. And really we should have been thinking, it's one eye only, it's unilateral. What the heck does that mean? Now back to this chap again. This is an anatomical sieve now. So when you start looking at the patient, start at the front. Start without a slit lamp. Again, look at the skin, look at the lids. Entropion, ectropion, redness, blepharitis, tight lids post-surgery. You know, people have had cosmetic surgery, their lids will be quite tight, and so on. Unusual blinking patterns. You're just quietly watching the patient. And this is involutional entropion. Now, when you are just quietly watching the patient, you might see them do a bit of a heavy blink and suddenly you see it. The lower lid just turns right in. They say, whoa there, and you might pull it out with your finger, just pull the lid back out. And then you might actually ask them to do it again. And of course, chances are they won't be able to pull it off, but they'll do a heavy blink and bam, in goes that lid. Now you've just done a non-invasive test for ocular irritation and you pretty much answered it. And you virtually don't have to do any other tests because you know what the problem is with this patient. They've got lid laxity and the lower lid is tending to turn in involutional entropion. And then you move in with a slit lamp. And you start looking more closely. Here's our gentleman again. Now he's got ectropion, obviously, and you look at other things: tylosis, trichiasis, aversion, cicatrization, anterior posterior bleph, and so on. Is he incomplete blinker as you're watching them, and so on? And we mentioned these two things: distraction test and snapback test. Now, does anyone know what they are? They're really, really important tests. To the college optometrist, and this is under ectropion, and it'll tell you what ectropion's about. It's horizontal lid laxity. It can also be due to cicatrization, paralytic, mechanical, tumor, and so on, and congenital. If you see it, this is interesting, the lower punctum is not in contact with the tear meniscus. Okay, we know that. And okay, that past example that you saw was patently obvious. But when you're just looking, you haven't touched anything yet, you haven't put any colored dye in or anything like that. If the punctum is spontaneously visible at the slit lamp, ectropion is present. So it might be very mild, but if you could effectively see the puncta like a volcano sticking up, then ectropion is present. Now, in a distraction test, if the lower lid can be pulled more than 6 millimeters from the globe, it is lax. And that means something to ophthalmologists. The snapback test is sort of the reverse of that. If you pull the lower lid down, it's how well does it snap back to the lid. And if it doesn't snap back very well, again, it's lax. And when you refer patients for this, you can put those terms in. Now that other patient before, we weren't distracting that lid. That lid was hanging out. So, you know, he's patently got lid laxity. And there's a good enough reason to refer. And you say, distraction tests show that the lids were lax. And that's basically often what ophthalmologists will use to decide whether to do surgery or not. Then you move in with the slit lamp. So at this stage, you haven't done anything with the slit lamp yet. But then when you go in with the slit lamp, you're looking at the tear meniscus, the volume and the flow, tear coverage and breakup time, blinking patterns. And you can watch it when you put the fluorescent in, you can see how far the lid comes down because you'll see a demarcation line. Well, I've written it there. Watch lid line demarcation of superior lid transit. I really like that term. I don't know how I came up with it. And you think, oh, yeah, that's it. That patient's not a complete blinker. And then the conjunctiva with the slit lamp. Is there conjunctivochalasis? Is there pterygia? If it is it raised? Does it stain with lissamine green? SLK, lid wiper epitheliopathy, inflammation, limbitis, chemosis papillae, and so on. So you're looking at these things and they're raised. And if they are the bits that stain, you can pretty much assume that that's why the eye feels a bit irritable. Now, it might not change what you do, but at least you can explain to the patient what's happening and if it's a very large pterygium, you might say, well, I think it might be best if we try to get that taken off. And then the cornea with the slit lamp. So again, we've already sort of alluded to these two patients. Positive staining, if it's pancorneal, if you lift the superior lid up and it's under the lid, it's more likely to be toxic. So that patient we said before, she'd been dumping in viscotears into her eyes, and if you lifted the lid up, it was the whole cornea was staining. But if it's only intrapupillary, then it's probably exposure. It might be poor blinking or whatever. Because the upper and lower lid have protected the cornea. And then there might be marginal keratitis and so on. But with negative staining, if it's bilateral, and ideally it links with the symptoms, so the patient will say, gosh, it's terrible in the mornings. During the day it feels okay, but then I go to sleep at night and when I wake up in the morning, it really hurts. And it might be the only sign you see, because when you see the patient, their eye is pretty white, their vision's quite good and so on, but you see this, so you put quite a lot of fluorescent in, and you see this scallop type appearance. It's never round, it's always a very scalloped shape on the front of the cornea, and that suggests that the cornea isn't a uniform, it's got ridges and troughs and so on, and the fluorescein pools, but it's very often the classic sign you'll see to go with the symptoms. Now, if it's bilateral, it'll be epithelial-based membrane dystrophy. If it's unilateral, it could be because they had trauma, the classic being a child's fingernail that lacerates the cornea. And okay, the initial process heals, but then some months later they come back and it's happening. The treatment's going to be the same. You're going to treat with a thick gel, Xalin or whatever, every night to try to allow the epithelium to bed down better with the stroma. So the mechanisms of harm. There's a bit of a ditty I've got called, well, it's called ditty. And you've got to break it down. Is it degenerative? Is it inflammatory? Is it trauma? Or is it infective? And so long as you can break it down to one of those things, you know, it helps you understand why we treat things the way we do. So the mechanisms of harm for dry eye is the hyperosmolarity, which is going to create trauma, and it's microtrauma through friction, and there's also inflammation. And that's what we have to work with, and that's how we have to treat things. So once you've discovered all that, so trauma could be exposure, it could be toxicity, it could be tear deficiency, it could be mucus, and it could be contact lenses. Inflammation is blepharitis, chronic microtrauma, and exposure can give you inflammation. And of course, degenerative, the classic one we see a lot is EBMD, which is a purely degenerative process. And it's a lot to deal with. And what, how long have you got for an eye exam? 20 minutes, half an hour, 40 minutes, maybe? Our most valuable treatment often is simply empathy and understanding and education. And really, it's best not to be prescriptive. Now, it was Michael Johnson that told me this. People's perceived control improves tolerance of pain. So it may not really look any better to you, but the patient feels better because they understand the problem. So you've got to advise that dry eye is a chronic condition with no permanent cure. You know, what else can you do? So many things. You say we can manage it, we cannot make it better. If the patient thinks it's going to take a drop for 10 days, it's all going to go away, they're going to be pretty disappointed. There will be good and bad periods, and that's a feature of the disease, if you call it a disease, and that all gives better compliance. And treat everything proactively that you and the patient can or want to. Right? I think clinicians can be a bit prescriptive about all this stuff, and certainly when you see the number of drugs that patients will be on when they come back from hospitals, it's just enormous. You think, wow, how can they possibly be compliant with all that? And you've got to give them a bit of an out on this, actually. You know, they've got to be part of the process, and you've got to be honest. And they've got to say, I'm not doing it. You know, if you're very prescriptive about it, really one of two things are going to happen. Either the patient's going to lie to you, or they're not going to come back, you know. And you've got to say, look, it is hard. And we've got to do the best we can with the time we've got and so on. And if you lapse a little bit, I mean, you're not trying to give them an out, but you've got to allow them to think, yes, I feel comfortable with this particular clinician. He's not going to get stroppy with me if I come back and say, look, I just wasn't able to do it. And I think that takes a lot of time. There's a lot of time involved there. So if you've got support colleagues that can do it, that's great. And I think you need to have people who are fully trained on this so they can take it over, because you might only have the time to do the actual clinical tests. But say, look, before you go, you have to be explained all this. You have to understand before you leave this practice. And of course, fact sheets and so on are very, very handy. We've written it all out. So again, it supports what we're doing. So the patient takes away things and it explains what each one's for. So with low-grade environmentally driven ocular irritation, it really is important to explain everything. The patient has to understand why it's working. And again, your leaflets or fact sheets help. But I usually start off, I have to explain two things. I first explain how a lid works, how the lids work. The fact that the superior lid does all the blinking, it goes up and down. The inferior lid does not go up and down, it goes left and right to pump the tears along down into the puncta. And of course, at that point, the patient will then understand why the lower third of the cornea gets least refreshed from tears. And that starts the ball rolling, especially if they've got a lid problem rather than anything else. You're saying that's why, A, your eyes water, but your eyes also feel irritable because the lower lid isn't pumping the tears along properly and they're flooding out. But also they need to know about the tear layers, the mucus and the aqueous layer and the lipid layer. And then they can understand why certain things are logical. For instance, if you've got very poor lipid layer, a liposomal spray suddenly makes sense, because otherwise, quite frankly, it sounds like black magic. You know, you're spraying on a closed eyelid. So the patient has to know why it works. So that's effectively, to me, step number one. They understand the problem then, and then you go on and start saying, well, what we can do. So you've obviously taken a good case history. You understand how the patient works. You can explain about avoiding or modifying dry environments, desktop posture versus tablet posture, and so on. Hydrate from inside out rather than outside in. Drink lots and lots of water. Fish, nutritional stuff, Omega, the dry eye, Omega eye drops, eye tablets, I should say. And blink rates. Blink rates is very important. You know, patients don't necessarily know that their normal blink rate is about 16 a minute, but when they concentrate on something, it actually drops to 4. And suddenly the penny drops as to why at the end of a long day at work, their eyes are feeling a bit gritty. And you know, the blink rate drops for everybody all the time when you concentrate. But at least when you're looking down at an iPad, your upper lid's pushing the tears down. Whereas when your eyes are wide open staring at a desktop, there's a lot more evaporative stress off the front of the eyes. Same when you drive, actually. You know, you're constantly looking in mirrors and you're concentrating, but your eyes are wide open. And so that sometimes then links onto the 20-20-20 rule. You know, and I know I always say to patients, look, the principle's great. The chances of you doing is pretty low. But, you know, every 20 minutes, look at something more than 20 feet away for about 20 seconds. I also use this term marinade. If I can't find anything really about their lids or whatever that I can actually fix, I'll often use a marinade approach where I say, you know, we put lots and lots of drops in at first and we gradually reduce the dose to a maintenance level where your eyes feel comfortable. And of course that leads on, I will never ever use preserved drops. I only use non-preserved drops. And I know they cost a little bit more, but I say it blankly to the patients. I said, you know, what would possess me to put toxins on your eyes? I just won't do it. You can buy them elsewhere if you want to, but you're not going to get them from me. So an awful lot of what we deal with irritable eyes is actually microtrauma. Exposure. For instance, if you've got very lax lids, you may have a good tear volume, but if the lids aren't distributing properly, the lower part of your cornea will be exposed and that causes the trauma. Equally, if you've got raised zones like huge pterygium and so on, they'll expose forward and of course they'll stain up with lissamine green and that creates trauma as well. We've already said toxicity with drops and so on. With tear deficiency, true tear deficiency, you'll often get mucus strands because the tear layers are out of whack. And for that we can use acetylcysteine, which is a mucolytic eye lube, and it's a very, very good drop. It does sting when it goes in, but if you've really got severe mucus strands causing irritation, it's really the only drop to get. And if you're not IP, you can always get it, obviously, from the doctor. You can get it prescribed that way. And also even contact lenses, you know, they are effectively microtrauma. And again, going all contact lensy for a moment, you know, if you've got a poor quality contact lens in your eye, have you got a dry eye? No, you've got a poor quality contact lens. You know, give people the choice of a good contact lens, and a lot of these troubles go away. And you know, blepharitis itself is a huge area. It's a term that's almost as bad as dry eye for just being a throwaway phrase. Oh yes, you've got blepharitis. Here, do this. Have some Johnson & Johnson baby shampoo, you know. Is it anterior blepharitis? Is it posterior blepharitis? Is it Demodex? And you know, those three conditions need to be treated differently. I mean, Demodex now, we've got fantastic meds for this now. It's just too easy. So instead of having a lid wipe that's not, you have one that actually targets Demodex as well. And you know, you don't really have to go to the extent of plucking a little blighter out and having a look at it. You know, if they're older and they've got greasy, matted up eyelashes, they've really got Demodex. So it's just simple to push them onto something that's going to deal with that as well as all the other things. Then there's corneal inflammation, ulcerative lids, and then the big one actually often with elderly patients is pure meibomian gland dropout. With those patients, it really doesn't matter how hard they rub and scrub their lids. There's nothing left to get out. So sometimes you've got to say, actually, gently is the way to go on these people, or not do it at all, because if there's nothing to get out, they're just going to scrub their lids raw. So you've got to give them all the information that you need on how to do it, what might help, and liposomals. So, for instance, those patients I was telling you about before that have meibomian gland dropout, liposomals make perfect sense there. You know, if you're prescribing these things appropriately, they're really, really good. So look, you explain how they work. Tiny droplets of lipid are reconstituting your lipid layer. You've got no lipid left. And also, it's easy to use. Most patients can spray things on their closed lids. So it's a very, very good one. But if you've got frank posterior blepharitis, then you're better off treating the posterior blepharitis. But if you've got gland dropout, then liposomals make perfect sense. With ulcerative lids, as an IPer, I'll often prescribe systemic antibiotics, or in fact, sometimes soft steroids if they've got corneal inflammatory involvement as well. So again, it's a complex thing. So you can't just say, yeah, blef. So coming on towards the end, this is really where I think it's almost ophthalmology stuff now. It becomes chronic. And I do think at times there are people with dry eye that really need to be under the hospital. Simply because fundamentally we're not funded to do something chronically. But you start throwing everything at it. And we've already said this, this, you get patients in and from the hospital and they're on just about everything. They've had their punctums occluded, they're on Omega tablets, they're on cyclosporin, they're on everything because their lids are in such bad shape, or their tears are in such bad shape, they have to do everything they possibly can. So finally then, here's a small quiz. Does anyone see how this clinical picture is somewhat flawed? So that lid is ectroped. Nobody's pulling it down. It's there. But bizarrely, they've had their puncture occluded. So again, this patient is clearly being diagnosed as dry eye. So someone's logic says, well, if your eye's dry, I better put a puncture in. But surely they would have been better off having the lids tautened up somewhat so that maybe the puncture could actually work. So there we are. Thank you very much for listening. I hope this helps. I hope it wasn't too boring.